Much, Susan, and welcome, Andrea. It's a pleasure to introduce you. Of course, a lot of the people in the audience already know you, but it's very special to have one of our own members speak at this newly minted biostatistics series for the core. I've known Andrea for a long time now. I remember you from our student days, and I remember you babysitting. So I've known you from right there till now when you have your own children. Uh, and uh, Andrea, many of you may know, is part of the respiratory diseases group here at the MUHCRI. And so many of her collaborations have been in the area of TB and lung diseases with that group. More recently, she's been collaborating with Dr. Brett Toombs. She's been involved in the DEPRESSD research group, and they have also been prolific, publishing some high-profile publications. Andrea's PhD thesis was in the area of generalized additive mixed models. She completed her thesis with Dr. Mikhail Abrahamowitz, whom many of us know as well. She's taught for a long time a course on correlated data at EBOH. And more recently, she's been teaching a course on data analysis and report writing. Uh, and she's published in a number of areas, but more recently, maybe in the past 3 or 4 years now, Andrea, you've been publishing on individual patient data meta-analyses. And I think this is a reflection of the fact that the data that's necessary for these kinds of analyses is slowly becoming more and more available. And when you do one of these analyses, or I mean, I think I haven't done a lot of them as you have, but indeed, this seems to be the correct way to do meta-analysis and not the aggregate meta-analysis that we've been relying on for so many years. I noticed that just in the last year alone, Andrea's been part of two high-profile publications, both appearing in the BMJ, one on COVID tests and another one on tests for depression. So I'll hand it over to you, Andrea. Very happy to have you, and I'm very glad Hydro-Quebec didn't ruin the day again. Thank you for joining us.
Thank you. That's a very nice introduction, Nandini, and I'm very happy to be here and very happy to have power this time and not have the power go out, just a few minutes before my presentation, which is absolutely a terrible feeling. So yeah, I'm going to be talking today about individual patient data meta-analysis and really with applications in the context of depression screening accuracy. And there we go. And I want to thank very much Brooke Levis, who gave me many of the very nice slides in this slide deck. So my plan is to talk kind of a little bit in general on IPDMA. I'll talk a little bit about how popular they've become lately, and a little bit about their advantages and disadvantages. And then I'll talk about using IPDMA to overcome problems in diagnostic accuracy research. So just to remind you all that individual patient data meta-analyses are the most specialized kind of review that you can do. They're right in the middle of this diagram here. There are a subset of meta-analyses, which are themselves a subset of systematic reviews. For a conventional meta-analysis, we collect summary measures from investigators or from published articles. And we might be collecting odds ratios or risk ratios or risks, but we're getting those from existing reports. And I'll call these aggregate data meta-analyses. In contrast, for individual participant data meta-analyses, we're collecting line-by-line data for each subject from investigators. And these have really become the gold standard of evidence synthesis. So this is just showing you from 1991 to 2008 that IPD meta-analyses were published with increasing frequency. This was from a published paper in the BMJ. But I thought that looked a little bit old, and so I wanted to know, well, what's happened since 2008. So I just did, you know, how you can do in PubMed, search up how many papers are published in a year on a given subject. And you can see the scales changed here, but that we've just had an increasing number of IPD meta-analysis published every year. So the flow of an IPD meta-analysis, well, the first step are all of the steps of an aggregate data meta-analysis. You know, you need to find relevant titles and abstracts and screen them for potential eligibility. Some of them may be excluded for various reasons. Then a subset go on for full text review. Again, some of these will be excluded because they aren't actually eligible. And finally, we'll have a pool of eligible studies. So as I said, these are all of the steps of a typical aggregate data meta-analysis. But with an IPD, we have another layer of steps where we now have to contact the authors and get them to agree to participate and to share their data. Of course, there's some authors that we can't find. There are some authors who decline to work with us. There's some authors who no longer have the data. Then they transfer the data to us. We spend time getting the data into a harmonized form so that, you know, all of those variables are coded in the same way and defined in the same way across the different studies. And now we have IPD that's ready for meta-analysis and for lots of other studies as well. So I'm going to give you the disadvantages of IPDMA right away. The first is that it's time consuming and expensive because it's so labor intensive. It takes a lot of time to find those authors, to get them to agree to participate, to get their data, to harmonize their data. It may be more prone than aggregate data meta-analysis to excluding studies, and that's because we have that extra step of having to get people to agree to participate. But methods do exist to combine IPD with aggregate data. And finally, you really need a lot of diplomacy because now you have this big group of people who might be participating in article writing, who certainly have opinions about all of the decisions that you're making. Yeah, so there's other people who do that, not necessarily me, but definitely diplomacy is needed. And the advantages. So individual patient data meta-analyses really can help reduce heterogeneity, and I'll talk more about that in 1 second. They are much better for investigating subgroup differences than typical aggregate data meta-analyses. They're very flexible with respect to the types of analyses that can be run. And the flip side to all that diplomacy is that they build large collaborative groups which are you know, interested in working together and interested in working together on the same problem. So one of the big advantages of individual patient data meta-analysis is that heterogeneity can be decreased. And when I say heterogeneity, I mean the idea that treatment effects or in the case of depression screening, maybe depression screening accuracy results vary across studies. And those effects can vary across studies because we have different study populations. You know, there are populations that are older or sicker or eat more broccoli, or because there's different study procedures, that there were different ways for participants to get into the study, or they use different measurement tools, or they defined their variables somewhat differently. And for all of those reasons, we have effects that vary across studies. With IPDMA, though, we can standardize inclusion and exclusion criteria. We can standardize exposure and outcome definitions. We can investigate the same subgroups defined in the same ways. We can use the same analytic methods, so the same model, adjusting for the same confounders, with the same treatment of missing data. And all of this together can reduce heterogeneity. So that's my very quick overview of IPDMA. And now I'm going to discuss some specific examples within the DEPRESSD project. So since 2012, Brett Toombs and I have been directing the DEPRESSD project, and we're interested in gathering and synthesizing large data sets to evaluate the accuracy of common depression screening tools. And using, sorry, I've got something blinking at me. Yeah, so that's a great question I have that is on the chat. It blinked at me from Anna, and she asks how investigators are responding to sharing their data and how do we address the ethical aspects of data sharing. So we have been very successful in the DEPRESSD group in getting investigators to share their data with us. You'll see our, do I show you those numbers? Well, you'll see how big our data sets are afterwards. And I think we have really good participation, like I would say over 80% off the top of my head. So I'm not 100% sure of that number. So, and I think that the longer that we do it, the more they can see that we are publishing interesting research and we're using the data to its full advantage, and they're participating in that. And so I think they're happy to share their data and to work with us for the most part. And the ethical aspects of data sharing. Well, we are working with data that is anonymized and within, for the most part, within the same goals that the data were originally collected. Yeah, I hope that answered that question. Okay, so the DEPRESSD project then, so we're interested in evaluating the diagnostic accuracy of the most commonly used depression screening tools. So at its basis, we're collecting primary studies that evaluated diagnostic accuracy. So they compared a screening questionnaire to a reference standard. So the reference standard is a diagnostic interview that would be used to diagnose depression. And the screening questionnaire is, you know, like a short number of questions that someone could fill out. And we're collecting basically sensitivity and specificity of the screening questionnaire. So yeah, so for the patient health questionnaire, we have 105 studies, over 46,000 participants. For the hospital anxiety and depression scale, we have 102 studies, 31,000 participants. For the Edinburgh postnatal depression scale, we've collected 59 studies, 15,000 participants. And our geriatric depression scale is in progress. So for all of these participants, we have, you know, individual level data, including the score on the screening questionnaire, whether or not they truly had depression, their age, their sex, the setting, and many other kinds of data. Yeah, so why have we done this? Well, part of it was to improve the quality of the data that was available for the diagnostic accuracy of depression screening questionnaires. So many primary diagnostic accuracy studies included subjects who were already depressed or already being treated for depression. And so those people really don't belong in a study that's evaluating a screening questionnaire because they shouldn't be screened. By using IPD, we're able to standardize inclusion criteria, and we can remove subjects like that from the data set. All of these primary studies use a combination, they use different kinds of reference standards across them. And these different reference standards were just combined in aggregate data meta-analyses because there wasn't really enough information to do it any other way. We're able to treat that a little more sophisticatedly, to treat it more sophisticatedly. In the meantime, we're able to look at it separately by different reference standards. There was also a lack of subgroup analyses. And the big one, which is what I'm going to be talking about today, is selective cutoff reporting. So in those primary studies, authors often were only reporting on their cutoffs that performed well. So this is showing you like the PHQ total score, and it could range from 0 all the way up to 27. And the most commonly used cutoff is 10, and we would consider that subjects with a 10 or above on the screening questionnaire have a positive screen and are likely depressed, whereas patients with a 9 or less have a negative screen and are likely not depressed. But you could assess any or all cutoffs in terms of diagnostic accuracy. So we could consider 10, but we could also consider, well, what about if we use 6 as the cutoff and considered subjects with a 6 or more as having a positive screen. And the problem is that many authors only report cutoffs that have high accuracy estimates. So we got onto this a long time ago. This was a conventional meta-analysis, which really kind of illustrates some of the problems. They had 18 studies, and each study reported sensitivity and specificity for one or more cutoffs. And the cutoffs that they reported were, well, you'll see. So here I'm showing you results from that traditional meta-analysis. And here we have the cutoff score from 7 to 15. And this is the number of studies that reported on that cutoff score. And this is the number of patients that were available for that cutoff score. So the first thing is that we can see that sensitivity actually increases from a cutoff of 8 through a cutoff of 11, which is just mathematically impossible. Sensitivity shouldn't increase as the score gets higher. Sensitivity should decrease because it would be identifying fewer truly depressed people. And the problem is really that we have different numbers of studies for all of these different cutoffs with different numbers of patients. So for cutoff 10, which is the standard, 16 of 18 studies reported on that cutoff, and we're just missing around 13% of cases. But for cutoffs below 10 and cutoffs above 10, we're missing, upwards of 50% of the data. So, Brooke Levis, for her master's thesis, did a kind of proof of concept, like could individual participant data help resolve this problem, and could we collect that data? So she went after those 18 studies, and she managed to get 13 of them, individual participant data. And pardon my dog. And this is showing you which cutoff the papers reported. So I'm showing you the optimal cutoff, and that was optimal according to Yeardens J, which is just the sum of sensitivity and specificity minus 1. And you can see that mostly authors would report the optimal cutoff and maybe some range around the optimal cutoff. Sometimes they'd report the optimal in 10, but there's definitely a tendency for authors to report the cutoff that performed well in their data set. So we considered usual aggregate data meta-analysis that took the available data from every study and pooled them at each cutoff, where the number of studies and which study varies by cutoff, versus IPDMA, which took the data for every cutoff. So every study gave information for every cutoff. And this solves the problem of selective cutoff reporting. So when we did that, so here again, you can see the cutoff from 7 to 15 I'm showing you. And you can see the percent of patients that were included in the published results. And we can see that for cutoff 10, we had most of the data with 83% of the patients, and our sensitivity estimate was pretty close, no matter if we did the conventional or individual participant data meta-analysis. But for cutoffs below 10, there was a tendency for the aggregate data to underestimate sensitivity. So you can see we have all negative estimates here, and to overestimate sensitivity for cutoffs above 10 down here. On the other hand, because specificity is really based on so many more people, all of the people who are truly not depressed, those results are the same no matter what we do. So this really demonstrates that selective cutoff reporting is a big problem, and that conventional meta-analyses that just take the available data for each cutoff and pool result in biased results. So that's great. So I think that we see that individual participant data meta-analysis can help to solve the problem of selective cutoff reporting because we have all possible cutoffs from all studies. But we were interested in whether we could use some modeling approaches to use just the published accuracy data and use like regression-based approaches to get at the same thing. So we did an empirical comparison of 3 methods for doing that. So the first was we used individual participant data with an IPD meta-analysis versus the conventional meta-analysis, which just ignored missingness, or 2 multiple cutoff modeling approaches, which attempt to correct the missingness. So we did this in the context of our Patient Health Questionnaire 9 data set. At the time, we had 45 studies synthesized. And we have a depression screening score from 0 to 27 for every subject and their true depression diagnostic status, yes or no. So for that individual participant data set, for each study, we considered all studies. So for each cutoff, we considered all studies. So there were 45 studies and 15,000 participants. For the published data set, for each cutoff, we only considered studies that published accuracy results for that cutoff. And so the data varies by cutoff. So for cutoff 10, which is the most popular, we have 37 of 45 studies reporting on that, and about almost 90% of the subjects. But for cutoffs less than 10 and for cutoffs more than 10, we have less than half of the studies reporting and less than half of subjects. So for our IPD data set, we used a bivariate random effects meta-analysis at each cutoff. So we estimated the model separately at each cutoff. And then we used, and then for the published data set, for the conventional meta-analysis, we did the same thing using the available data at each cutoff. And we used these 2 modeling approaches. These approaches take all of the data that's available in the published data set, and they kind of fill in the gaps. So if we take a comparison of the model, the bivariate random effects model analyzes each cutoff separately. It takes into account the correlation between sensitivity and specificity within a study, but it ignores the idea that there's correlation across cutoffs. So what's happening at cutoff 9 is related to what's happening at cutoff 10 or cutoff 11 within the same study. It completely ignores that other level of correlation. On the other hand, it makes no assumption about the functional form between the cutoff or the threshold and accuracy. So we're not assuming that sensitivity is related in a parametric way to the cutoff. It's very non-parametric in that way. And it's a generalized linear mixed model. So we are accounting for the fact that our outcome is binary, and our random effects are normally distributed. For the Steinhauser modeling approach, we analyze all cutoffs simultaneously, accounts for the correlation of accuracy across cutoffs. So it's accounting for the complex dependent structure in the data. But it does so at a cost, and that cost is to assume a parametric association between the cutoff and logit sensitivity and logit specificity. And it's a linear mixed effects model. So we're relying on a normal approximation for our outcome and normally distributed random effects. And finally, the Jones modeling approach, which is similar to the Steinhauser one. It's modeling count data directly using a multinomial likelihood rather than requiring normal approximation. There's a bit more flexibility in the assumed association between cutoff and sensitivity and specificity. And again, it's a generalized linear mixed model. So you can see that we're going to see differences between the approaches that we use. And there's lots of reasons that we might have differences between any of these different modeling approaches. So the first thing I'm showing you is the ROC curve when we apply the bivariate random effects model to the IPD data set. So it looks good. We're happy with it. If we apply the bivariate random effects model to the published data set and just estimate the overall sensitivity and specificity using the data that's available at each cutoff according to what was published, we get something that really doesn't look very good and is not very close to the ROC curve that we get from the full data set. So we already knew from our previous work, but we see it again that the typical approach to an aggregate data meta-analysis using available published data doesn't work very well. So what happens when we use the more sophisticated approaches? So this is the Steinhauser approach, and this is the Jones approach. So you can see that they both do well. We apply them to the published data, and we get an ROC curve that looks quite like what we get from the IPD data, from the full IPD data set. The other thing that we can talk about is the area under the curve. The AUC is actually super similar between all three approaches, as we can see it already. Okay, so now, we were pretty happy to see these kind of results. Hi, Nandini. Nandini's asking, why does the BREM perform worse than the other two methods? Do you mean when I showed you this one?
That's right.
Yeah.
Maybe you're going to answer it later in your talk. But
yeah, no, this is, so the difference here is that the black one is the BREM applied to the IPD data set, and the BREM applied to the published data set is just using what's available, what was published at each cutoff. And the primary authors are often reporting cutoff, like they're choosing which cutoffs to tell you about based on what's working well in their data. And so as a result, you really just get a biased.
All right. So perhaps I misunderstood. I thought that the Steinhauser and Jones models also use the same published data.
They do use the published data set, but they're using the aggregate, all of the information from the published data set at once. So rather than,
I see.
This is estimating it just, using the studies that published for this cutoff. They're using the whole thing. And when they do that, they're able to fill it in better, I think, in terms of what we see. So, right. So, yeah. So then we also want to see, well, what if we apply those methods to the IPD data set? Because obviously there's some differences here in terms of the data set, there's differences in terms of the model. So we were trying to understand a little bit the strengths and weaknesses of various approaches by applying these methods to the full IPD data set as well. And when we do that, again, the Jones model comes very close. It's quite similar to what we got when we used the bivariate random effects model on the IPD data set. And the Steinhauser one had this kind of underestimation of sensitivity at the upper cutoff. And this, I think, has to do with the global nature of the fit, where it's prioritizing fitting sensitivity well down here, where there's more data than up here. The Jones model is doing a bit better because it has a more flexibility built into that association between cutoff and sensitivity and specificity, whereas the Steinhauser approach, I think, just looked at either like a linear association or a log linear association, I believe. Yeah, so we see that there's kind of like some slight differences. And again, there are some differences in the area under the curve, but again, they're all pretty close, close to 90%. So we can think about this idea of like, well, do we want to obtain and meta-analyze IPD, or do we want to work with the published data? So IPD is obviously, it's the gold standard data format, but it's a huge amount of labor to obtain and synthesize that data. Working with the published data, on the other hand, and using like the modeling approaches of Steinhauser or Jones is more efficient and produces similar results. On the other hand, we had better precision when we used the IPDMA because we had more data. And we have fewer assumptions. I quite like the fact that we don't have to make any assumption about the shape of the association between cutoff and sensitivity and specificity. Here, we have to make more of an assumption about what that shape looks like. On the other hand, we're not doing as good a job with this approach in terms of the dependencies in the data and modeling those complex dependencies across and within cutoffs, within studies. And when we use the modeling approaches, we are doing a better job of that. And finally, once we've collected that individual participant data, there's so many things that you can do with it. We can look at participant subgroups. We can take care of some of those other problems that I mentioned earlier with diagnostic accuracy information. And there's lots of other questions that we can answer using this data. And when we're working with the published data, well, we have much less opportunity to investigate participant subgroups or to investigate alternative research questions. Yeah, so, but we did see that if we're working with IPD, then the three methods do perform relatively similarly. So just to point out that this is definitely an empirical comparison of several methods. So we don't know the truth, and so it's hard to say that one method is better or worse than the other. The bivariate random effects model is recommended in the Cochrane Handbook for diagnostic test accuracy, but it might not be the gold standard for analyzing data of this type, and that's because it ignores the within study correlation across cutoffs. And to your second question there, Nandini, yes, it analyzes each cutoff separately, pretending like that's the only cutoff. So the modeling approaches might be preferable when analyzing diagnostic test accuracy, even when it's IPD, because they use all the data at once. They make explicit use of the cutoff. They account for those complex dependencies in the data, but they come with additional assumptions which may or may not be met in a given data set. So this so we were interested in this idea of investigators choosing the best performing cutoff in their study sample. And so we were interested in how small samples and data-driven optimal cutoff selection work together to cause bias in diagnostic accuracy estimates. So this is some work that Brooke Levis did as part of her PhD thesis. So we were working with our EPDS data set, and we defined the population as all of the data from our 49 EPDS studies. And we took samples, drew them with replacement from our EPDS data set. So we took 1,000 samples of size 100, 1,000 samples of size 200, 1,000 samples of size 500, and 1,000 samples of size 1,000. And we looked at the optimal cutoff and the sensitivity and specificity of that optimal cutoff in those simulated samples. And we compared that with what we got when we looked at the overall EPDS IPDMA data set. And here our optimal cutoff was defined as the cutoff with a maximum units J, so with a maximum sensitivity and specificity -1. So just to repeat that, we had our full data set. We drew samples from it. And for each of those samples, we found the optimal cutoff and estimated its sensitivity and specificity. So here I'm showing you the optimal cutoff by the size of the data set. And you can see that with a small data set, we had a really big range of optimal cutoff from 5 up to 17. I believe the EPDS goes to a maximum of 30. But so super wide range, and that range, as we would expect, got narrower, but still had some variability even when data sets were of size 1,000. And correspondingly, we can see that so I'm showing you here the estimated sensitivity across those 1,000 samples, and the dotted line was the sensitivity for the optimal cutoff in the true full EPDMS data set. And so you can see that we had an inflated sensitivity for the smaller data set that kind of came down to not so much bias for the biggest data set. And as our kind of other results have hinted at, we really didn't see very much of anything going on with specificity. And that is because in those small data sets, where the proportion of depressed is maybe around 15%, there's really few depressed cases in a small data set. And so moving the threshold just a little bit results in really big differences in sensitivity, but not so much difference in specificity. And we can look at that. So I'm showing you here the bias, so the sensitivity in these samples with their optimal cutoff compared to the sensitivity in the overall data set, and it was too big by 6.5 in the smallest data set, and that decreased to 4.2 to 1.8 to 1.4, whereas specificity was always, just around 1. So this really kind of made us extra aware of being wary of small samples in this context. And often what we see is our primary studies concluding that an alternate cutoff is necessary in their study population because their study population is old ladies, or maybe it's people who eat broccoli, or for whatever reason. And we now are much more likely to think that it's probably because they have a small sample size. So I'm just about at the end here. So yeah, so the tendency of primary studies to report accuracy only for well-performing cutoffs, I think we've seen that, and we think that really it's most likely chance and not specific characteristics of the study population. And doing a usual aggregate data meta-analysis of published accuracy results really results in a nonsensical ROC curve and probably biased estimates. IPDMA solves the problem and allows other kinds of analyses, but modeling approaches of published data also work. And thank you. And then I would like to acknowledge the whole DEPRESSD team, who are a great group of people, smart and working hard, and CIHR for funding. And I would be happy to take your questions.
Thank you very much for that talk, Andrea. I'm sure many people are curious about IPD meta-analysis, and I hope you've answered some of their questions. Does anybody have any questions? Please either speak up or you can type into the chat. I'm going to allow myself a question while we're waiting. So I just want to understand, Andrea, you have been describing this work as IPD meta-analysis, and I just want to make sure that the analyses that you presented that were where there was a lot of missing information, are those not also IPD meta-analyses in the sense that these are diagnostic studies and the data that's coming from each study is a 2 by 2 table at a certain threshold? So in a sense, you do have individual patient data.
Yeah, in a sense, we do.
Okay.
And for sure, if a study were to give us all of that information for every cutoff, then we would essentially be able to recreate this, the score on the screening questionnaire for each person. So
Okay.
yes, but for sure to collect that information for published accuracy results is quite easy. But it's not quite IPD because you're missing all of the other cutoffs. You just have the cutoffs that the author chooses to share with you.
Correct. And in fact, the cutoff is not specific to a subject, it's not specific to the individual. So, am I correct that what you're doing in this more elaborate exercise is to gather the continuous test result and not just the dichotomous test result?
That's right. Yeah. So for our
Okay.
IPD, we collect the screening score, um, their diagnosis status, so whether they're truly depressed or not, and
All
then
right.
all the other stuff, age, sex, because we're interested also in subgroups and in evaluating, whether the diagnostic accuracy is the same, for different groups of people.
Thank you. Any questions from the audience?
Oh yeah, Raman's asking, is there any information about using other diagnostic indicators such as NPV and PPV? We don't typically work that much with NPV or PPV, and that's partly because the prevalence still varies quite a bit across the different studies. So it can be anywhere from maybe like down as low as 5% to up as high as 30%. But I think like a lot of the same things would apply. The same kind of caveats as to using published data or IPD. So Nisha's asking, how easy is it to harmonize data from different studies? Have you ever had to exclude studies because it was impossible to harmonize their data? It is not easy to harmonize data from different studies. I don't really do that, but I hear from my team that it's hard work, and it takes a lot of time. It often takes a lot of back and forth with the investigator to try and understand exactly what is going on in that data. And one of the things that we've noticed is that sometimes what's in the published paper is wrong. There are mistakes, things are backwards that we discover when we get the raw data. I don't think we've ever had to exclude a study because it was impossible to harmonize their data. Once we have an agreement from an author, we'll work pretty hard to get the data into our hands in a way that we can use it. But it's a definite challenge and it's super labor intensive.
Andrea, I remember that in the early days of this IPD meta-analysis, there used to be a debate in the literature about one-stage analyses versus two-stage analyses. And I think in two-stage analysis, you analyze every study separately and then you do a pooling.
Yeah.
Is this kind of debate even relevant to the kind of studies you're doing? And
well, we actually use a two-stage approach, but we could use sometimes we do it at one stage if we're interested more in subgroup effects. So we do different things depending on what our goal is. I think that a lot of the time it doesn't make such a big difference. And with a two-stage approach, you still get all of the benefits of the harmonization part of an IPD, right? You can still define your outcome the same way and define your exposure the same way with the same inclusion criteria. You can use the exact same model in every study and then pool it using like standard meta-analytic techniques. Yeah, but with a one-stage model, you have a little bit more flexibility, especially in terms of like data variability. Like if you have zero exposures or zero outcomes in a study, it can still go into the one-stage model. Doesn't work necessarily in a two-stage model. So I don't know. I think there's still like lots of chatter, but we'll use which one seems most appropriate depending on our objectives.
Hi, this is Susan. Someone sent me a question directly by accident, so I'm going to read it out for you. From a pragmatic perspective, how long does it take to run an IPDMA versus the traditional MA? What would be the factor that would decide going for the IPDMA?
Yeah, so I think I showed you at the beginning, to do an IPDMA, you have to do a conventional meta-analysis first, because you really have to find those studies, and all of those steps of finding the studies and determining whether they meet your inclusion and exclusion criteria are the same for traditional meta-analysis and an IPDMA. But definitely gathering the information from a publication, pulling out odds ratios across a bunch of papers is much quicker than contacting the author, convincing them that it's a good idea to work with you, having them send their data, figuring out what their data set means and harmonizing it and all of that. It's like orders of magnitude more difficult. So why would you want to do that? I think you want to do that when a conventional meta-analysis is not going to do a good job of answering the question. So for us, I think in terms of diagnostic accuracy, that published data doesn't answer the question that we're interested in answering. We weren't able to do subgroup analyses where we were really interested in understanding how diagnostic accuracy might vary across subgroups. We weren't able to, with conventional meta-analysis, we weren't able to investigate whether loading the sample with people who are already depressed or already being treated for depression, how that biases accuracy estimates. So those were the reasons why an IPDMA made sense in our context. And I think you should think about whether a conventional meta-analysis does the trick, in which case that's much easier, but it might not answer the question well.
Other questions? And what about covariates? Okay, wait a minute. Here's another question from someone. Do you ever include unpublished data?
Do we ever include unpublished data? Yes, I think we do two things. First of all, sometimes we include data where the goal wasn't necessarily diagnostic accuracy, but they do have screening questionnaire data and they do have diagnosis, like a proper diagnosis of depression. So that's kind of like that. Have we included unpublished data? I'm not 100% sure, but we would if we thought it was well-conducted research and just hadn't been published for some reason, that we wouldn't have a problem with that. Nandini, you're going to ask me about covariates?
Yes, I was just indeed wondering, is it just 2 by 2 tables at each threshold that you have access to in your data sets, or?
No, we have age.
Covariates. Okay.
Yeah, we have age for sure for everyone pretty much. We have sex. We definitely have setting, like whether it was administered like in an outpatient setting or in a hospital or inpatient setting. We have some information on comorbidities. For the EPDS, we have information on like what trimester of pregnancy the woman is at, or whether it was after birth, like and some other kind of pregnancy related information. Yeah, so it's like we have quite a lot of different kinds of information. Of course, it's like it's not all complete because different studies collected different bits of it, but for sure for like the PHQ, we definitely have age, we definitely have sex, we definitely have setting, and then other ones as well.
Right. And I presume that then, so if subgroup analyses are of interest, then that's where the IPD meta-analysis is really advantageous over the aggregate.
Definitely. Yeah. Yeah, that's one of the big wins. I mean, after, I guess, reducing heterogeneity, the next place where IPD really outshines aggregate data meta-analysis is in the ability to detect and estimate like patient level interaction with treatment, or I guess in our case would be like differences in diagnostic accuracy across subgroups. So we have not found that much evidence for important subgroups in diagnostic accuracy anyway.
Thank you. Any other questions from the audience? All right, I'll just wait another minute, Andrea, just to make sure. This is the challenge with online presentations. So what are your future plans?
Yes, what are our future plans? Well, we are working on compiling our geriatric depression scale. And one of the interesting things about that is we have less access to the data, or we're having less success in gathering the data. I think that's maybe, I won't speculate. Anyways, so I think that our main, some of our main approaches might be to use like the modeling approaches, like the Jones approach or the Steinhauser approach, because we're not able to gather as much information as we would like, or get as much of the IPD as we would like. That could be due to the age of the data sets. That's one of the big stumbling blocks in terms of gathering data. One of the other things we're interested in doing is right now we're looking at the predictors of sharing data. So we have quite a lot of information on primary studies, whether they shared it with us, whether they didn't share it with us, and so we're interested in doing that.
So a question from Rebecca.
Hi, Rebecca. Have some of the collaborators who shared their data changed their screening threshold value? I don't know if they have, but we have definitely had collaborators who have reached out to us and said, oh, I work with Parkinson's patients, or I work with blah, blah, blah. Can you tell us about the evidence whether the threshold should be different in my special, my specific patient population? And for that, we've been sharing those simulation results where we show them that just by chance there's a huge variability, and they're probably best going with just the standard cutoff. The other thing is that actually our meta-analyses have, well, for the PHQ anyways, we showed in our the primary results that the cutoff of 10 was the best cutoff. For some of the other screening questionnaires, there's a little bit less consensus around what is the standard cutoff. Like in the EPDS, I think there's 2 or maybe even 3 cutoffs that are standardly used. And so then it's harder to say, well, anyways, the optimal one was like in the zone, wasn't a completely different cutoff. but for the PHQ, the optimal one was this one.
So I have another question, Nandini.
Yes, of course, and Rebecca, please.
No, it's related to your question about subgroups, but it's not totally. Does it make sense, do you think, that the same threshold would be appropriate in different cultures?
Yeah, that's a great question. I think that's probably the place where there's maybe the most like a priori kind of idea that a different threshold would make sense. And it's also the one where we're in some sense is the least prepared to answer it because we don't have enough geographic diversity in our data sets. Yeah, but I think culturally, how people think about their feelings, think about answering these questions, think about, yeah.
And expressing, you know, the emotion with some of the items in the questionnaire. Yeah. Anyway, thank you.
Thank you.
And my last question to you, Andrea, that is, what software are you using to do all these methods?
We use R.
Okay.
Yeah.
All right. So something is, you know, for example, I know the Jones method,
Yeah.
they published a Bayesian program.
It's a Bayesian, yeah. Yeah, actually, you know, one of the interesting things about that piece of work is that we collaborated with Gerda Rucker, who was, I can't remember Ms. Steinhauser's first name, who was Ms. Steinhauser's advisor, and with Haley Jones. And they, we actually sent them the data, the published data, and they did their own analyses, blinded to the results of the IPD data. And then we put the results back together at the end. So I know the Steinhauser method is available in R, and that's a good question. I'm not 100% sure about Haley Jones.
Okay, right. Right. Thank you very much. That was a very interesting talk, and it's nice to find out what you are doing. And so clearly now, if anybody wants to do IPD MA, you know who you need to talk to in our milieu.
Thanks so much for having me.